This afternoon's panel is on complications. My talk will be on neurologic complications. That'll be followed by Katie Arndt from Mayo Clinic in Rochester, and she'll be looking at epidural fever. And then Rachel Kakmar from the University of Colorado will be talking about post-dural puncture headache. I have no disclosures. So to begin, what I want to do with this talk is I really divided it into two parts. The first part is on injuries that occur from neuroaxial blockade specific to obstetric anesthesia. And the second half of the talk is really on intrinsic birth injury. We're going to talk a little bit about the rates and frequencies of these complications, how to diagnose them based on various signs and symptoms, things that make parturients at risk for them, and how to prevent them, as well as how to manage these unanticipated events. To begin, I wanted to have a quote by Hippocrates. I think most of us are familiar with the do no harm, but I felt for this talk, life is short, the art is long, and experience treacherous. And what I mean by this is for these nerve complications that can be quite rare, you may only get one in your entire career. So to rely on personal experience or local experience of practitioners around you or at your institution really may not be enough. And this is something that you need to go into the literature about, be familiar with a lot of the multi-institution studies that are going on and some of the national databases that are taking place to get a better grasp on these injuries. Okay. So we've divided them into two parts. You can see up there the different types of injury from neuroaxial blockade and obstetric anesthesia, and then those intrinsic to childbirth, from delivery methods, positioning, and in some cases ischemic injury. Before we get into the specific rates of the anesthesia causes of neuroaxial injury, I think it's really important to know to go to the specific type of patient. So we're only going to talk about obstetric neuroaxial injury. And to give you an example why that's important as opposed to going to the general literature, this past year in 2015, ASRA came out with some practice guidelines, and they went over rates of neuroaxial injury. And as an example, they quoted a study from Sweden that had about 1.7 million people in it. And for example, if we just looked at spinal hematoma in obstetric patients, the rate was about 1 in 200,000 because you had young, healthy women. But if you looked at spinal hematoma for hip repairs in elderly women, the rate went up to 1 in 20,000. And if you looked at spinal hematoma for procedures from knee arthroplasty, it was as high as a little bit over 1 in 4,000. So my point is it's really important to just look at the literature for the patient population that you're taking care of. So we have a study from 2006. This is about 1.4 million women. It's a meta-analysis of 27 studies that were in the literature. And you can see the rates there of epidural infections, about 1 in 50,000, epidural hematoma, 1 in 70. The persistent neurologic injury means nerve injuries that lasted more than a year. And then we have the transient neurologic injury. Now the authors were very astute in pointing out in the discussion that for the transient neurologic injury, they couldn't tell from this study, from their retrospective analysis of the literature, which ones were associated with epidurals, which ones were intrinsic to childbirth. And the other problem we have on really communicating these rates of rare events to our patients, if we take this study, for example, they had just a total of 6 epidural hematomas. I didn't put the confidence intervals up there, but it really goes anywhere from about 1 in a million to 10 in a million, right? And you just have this huge range. Okay. So we'll go forward a little bit to 2014. We have an effort started by SOAP for serious complications related to obstetric anesthesia. It's a SCORE database that we have 30 participating institutions that give data regarding these rare obstetric anesthesia injuries. The next slide here highlights the one specific to obstetrics. A little over 250,000 patients were in this database. And again, rates not that dissimilar from the prior study, but they're quite rare. And so as an example, for these 1 in 250,000 anesthetics, there was only one case of epidural hematoma. So again, you have a huge range of confidence intervals. When we look at the closed claims database, a study from 2009, again, these are legal claims that have been completed. Some of the difficulties with the closed claims database that I'm sure you've already heard about is there's really no denominator. We don't know all the injuries that occurred. And what we do see in this study, though, is that we have closed claims before 1990 and those after 1990. And we really see a change in what people are being sued for. So maternal death, fetal brain damage has gone down significantly. And what has increased and made up the difference is maternal nerve injury. Okay. Now, the good news is that for the maternal nerve injury, even though it's the most common, the settlements in about 2007 from 2007 averaged around $125,000 for the claims that paid out, and this is different than things that averaged around $1 million for maternal death and neonatal brain damage. It's also interesting to note that in the maternal nerve injury part of this closed claims database, only a third ended up in money coming from the anesthesiologist, and the other 2/3 there wasn't any payment. So let's talk a little bit more in depth about some of these rare neurologic injuries. Epidural abscess, I think everyone's familiar, but we'll just review it. So signs and symptoms. It often takes a few days for this to present, 4 to 10 days typically. Signs are backache, tenderness over the spine with palpation. Most common organism is staph. You have fever, headache, often neck stiffness. Having an elevated white count and sedimentation rate can also be helpful. As soon as you have any suspicion of this, you want to do an emergent MRI. Gadolinium is typically recommended because it enhances a lot of the inflammatory component of the lesion, and start on antibiotics even without knowing exactly what the bug is. And in many cases, surgical decompression is needed. The other type of infection with epidural placement is meningitis. Now, meningitis specific to postdural puncture has a very different bug. It's normally strep viridans, and we have case reports where it's been tracked back to the anesthesiologist who's placed, say, the spinal block that's gone through the dura. Things to prevent this, I think, are rather common sense. Appropriate sterile technique, gown, gloves, hat, so on like that. But luckily, both of these are quite rare. Epidural hematoma, you have this acute back and radicular pain, numbness and weakness in the lower extremities, and then frequently you have urinary and bowel dysfunction. This again is really an emergency for getting the imaging done with MRI and neuro consultation as well as neurosurgery. The time frame you're looking at is that we have studies that if it's been more than 6 hours, 6 to 8 hours since the lesion was picked up with symptoms, they often don't recover. So you have a really fine window of getting them to appropriate decompression and treatment. Okay. So I'd shown you a picture of an abscess. We'd shown you a picture of an epidural hematoma, and I have another image up there with some arrows. I'm going to have people just think about what they might be seeing there. And then another image here. Okay. So what these are normal MRIs after someone has had a epidural placed for labor analgesia. And this was a study in 2010 where they took 15 women who'd had CSEs done and had catheters for labor analgesia. MRIs were done within 12 hours after birth. And then another 15 women who gave birth but did not have epidural anesthesia. And the reason I think it's important is we don't do imaging a lot for epidural hematomas and abscesses. And what this study shows is that it's very common to see air in there. It's very rare, and in this study of 15 women, 0, is there any mass effect. So the point of the study is if you do the imaging and you see any mass effect or thecal compression, you want to be very worried about a central process of either epidural hematoma or abscess, because none of these had that. Needle tracks are very common, tissue edema and air, but not the thecal compression. Okay. Well, what about direct trauma and injury? So there's other ways that we can injure nerves, direct trauma to the cord, to the conus, to radicular injury to the roots, or neurotoxicity from putting the wrong drug in the epidural. Okay. So for this, the discussion is what can we do to limit these injuries of hematoma, infection, direct trauma. Most of them in the literature I think are very common sense. Stop needle advancement if there's pain, right? Don't inject if there's pain or if it persists. I think we're not good at finding the exact level of the vertebra. That's been shown in studies, so making sure we go low for the spinals, and always double checking your drugs, wearing hat masks, and appropriate sterile technique. Okay. So that brings us to intrinsic injuries of childbirth. The ranges here are quite variable, anywhere from about 0.6 to 92 per 10,000. The 92 brings us to approaching almost 1% of all childbirths having some sort of intrinsic birth injury. And what we find when we look at the literature is the studies that have that high percentage are ones where they're not only prospective, they went and they called the women at home later on and did direct patient follow-up as opposed to relying on the chart. The good news is most of the symptoms from these intrinsic birth injuries improve or resolve usually in about 6 to 8 weeks. There's a variety of risk factors for them. Prolonged second stage and having it be the first child are really well described in the literature. The ones with the question marks are a little bit more iffy. Part of the problem is many of the studies that we have when we look at risk factors, a large percentage of the women have epidurals, so it's often hard to tease out whether having an epidural would be a risk factor. And to give you an example of how it might be a risk factor, if you have significant labor analgesia, some of the symptoms the woman might begin to have from stretch or compression injuries might be masked. If you have significant motor blockade from your labor epidural, the woman might not shift position in the bed as much and might have compression or ischemic injuries that way. Operative delivery, malpresentations of the fetus, in some literature have been felt to be risk factors. With certain nerve injuries, they certainly are. So this is just a table of all the different intrinsic nerve injuries that you might see from childbirth. Lateral femoral cutaneous is the most common. That's somewhere between 1/4 and 1/3 of all intrinsic birth injuries. Femoral nerve injury is the second most common. We'll take a little bit of time to go through each one of these. So lateral femoral cutaneous, you can see the nerve there coming from the second and third lumbar roots. It's a fairly superficial nerve going under the ilioinguinal ligament. Sometimes it goes through the ligament. What you see if this is impinged, if these are compressed or stretched, is a sensory deficit along the anterior lateral thigh. There's risk with prolonged hip flexion or belt pressure at the waist. It's a purely sensory nerve, so there's no motor component to it. Obesity and diabetes also are risk factors for patients with this. Femoral nerve, you can get injury by compression under the inguinal ligament also. Again, hip flexion and weakness at knee extension are the symptoms that you see. You also lose the patellar reflex. The sensory component of this nerve is over the anterior thigh, and then it extends down into a saphenous component over the medial calf. Risk factors are prolonged periods of flexion, abduction, and external rotation. Unfortunately, those three components are very common with vaginal delivery and do put people at risk. If you're having a cesarean section, retractors have been implicated by compressing this nerve against the pelvic wall. The obturator, so the prior two nerves, the lateral femoral cutaneous and the femoral nerve, are more from positioning and external injury. Now we're getting into nerves that are really within the pelvis and are more from the fetus or forceps. So fetal retractor compression on the pelvic wall can injure the obturator. Lithotomy position can distort the obturator canal and cause injury. Symptoms you see are weakness of hip adduction and internal rotation. And what this creates is sort of an abnormal gait where, because the patient can't adduct the leg, they sort of swing it around in a circumduction as they walk. You have sensory loss at the groin and medial leg also. Okay. Lumbosacral plexus injury, again, a large set of nerves all the way from L1 down to S4. They're very variable in how they're injured and the presentation. Commonly, though, you have a common peroneal nerve involvement. So you'll often have foot drop with this, but not always. This can resemble peripheral nerve lesions, plexus lesions, or multiple root levels. Some things that increase the injury rate are large fetus, malpresentation, having a small pelvis. Most of the time it's unilateral, but sometimes it can be bilateral, and you will often need to rely on neurologic studies or consultation to better pinpoint exactly where this injury is if this plexus is involved. Sciatic nerve, so you have stretch injury from the lithotomy position, improper leg extension, external hip rotation. The number one cause in the past had been misplaced gluteal injections, where the injection was actually into the nerve. Again, because of the peroneal component, you usually have sensory loss over the 2/3 of the lateral leg and dorsum of the foot, little weakness with knee flexion, and again, you can have foot drop with this injury also. And then again, specific to the peroneal nerve, normally this is just sensory loss in that lateral 2/3 of the leg and the foot and toes, weak foot dorsiflexion, foot drop. And how does this nerve injury occur? Misplacement where it's having compression of the fibular head by stirrups or poles, the side rails of the bed. There have even been cases where the mother's hands in bringing her legs back have compressed this nerve laterally as she holds her legs back while delivering. Okay. So I put a chart in here because the last three nerves that we talked about all have foot drop in them. And so when you get foot drop, it can be very difficult to diagnose. But some things to think about are, is there pain involved? Where's the weakness? And doing not only a sensory but a reflex exam can sometimes help. Things that can help differentiate nerve root injuries are actually examining sensation over the lower back and the paraspinous muscles. There's innervation directly from the nerve roots to these paraspinous muscles, so if the nerve roots are taken out, you often have weakness in those muscles or decreased sensation over the lower back. But either way, any type of nerve injury should really invoke sort of immediate assessment of the patient. A full H&P, obviously, and then ideally, you've already learned of any pre-existing nerve injuries prior to the patient going into labor. The onset, the timing, is the weakness and sensory loss progressing? Is it staying the same? Looking at the paraspinous muscles and sensation in the lower back. I have a table for you in your syllabus about EMGs and nerve conduction studies. But in general, if you choose to do neurologic consultation, which I think anytime you have bilateral or motor deficits, it's a very good idea to do that. I think, if it's a lateral femoral cutaneous nerve and just sensory that's stable, that's something else. But the EMGs and nerve conduction studies help differentiate between axonal degeneration, the timing of the injury, and the location. It turns out that it often takes up to 3 weeks for there to be EMG changes distal to the site of injury. So you may want to do them early on, although it's not frequently done, just to see if you were concerned for pre-existing injury. And then if you wait a few weeks, you may have axonal degeneration, or as opposed to just demyelination. In a patient that has significant nerve injury, it's important to do physical therapy referral. And in some cases, if you're worried about chronic pain syndromes, referral to a chronic pain center so that they can get appropriate education and expectations about where the nerve injury will go. Medical legal implications. Again, we talked about the closed claim that currently nerve injuries are the leading cause. Things that help mitigate legal suits, effective communication. And it turns out that some of that effective communication really needs to be at the start when you first meet the patient. In studies that have been done, most pregnant women do want to know all the complications, even the rare ones, and so communicating those well early on can help if there is a nerve injury. Sort of prompt assessment of the patient and getting treatment lined up right away helps. And good communication with other providers. I think it helps a lot if you have a neurologist in the hospital who really wants to specialize in obstetric nerve injuries. A lot of these are difficult to diagnose and need a little bit of forethought and experience about, but staying in very good consultation and communication with the neurologist as well as the obstetrician helps a great deal. Other things that have been mentioned are separate consent forms for neuraxial blockade for labor that really go over in a little bit more detailed manner than a general consent form, the things that are specific to that patient population. So in summary, luckily these serious permanent neurologic injuries are quite rare, but the intrinsic birth injuries are not, and may be as frequent as 1 in 100. Regardless, prompt recognition, diagnosis, and treatment is really key, and then keeping in good communication. So finally, I'll end with a quote from Twain. "A thing long expected takes the form of the unexpected when at last it comes." Just again, the idea that so many of these are rare, but it's definitely something you want to be prepared for, because if you get the diagnosis right away and the imaging, the paralysis that could result from, say, epidural hematoma might be mitigated. So thanks.